शेयर भएको हो कि हैन
बाछ सर
स्लाइड आयो
बाछ सर
लाइट अफ गर्छु कि धेरै उज्यालो टल्क्यो Okay, good morning everybody. Okay, am I audible to all of you? Response नै छैन सुना हो कि हैन ए ल ठिक छ सुन्नु भएको छ कि छैन Okay, let's proceed with ZMC fracture. Most probably today is the last topic, last class for maxillofacial fractures. From tomorrow we start a new class with new topic. So method of fixation. In case of ZMC fracture, it varies from no fixation to 5-point fixation. Okay. So depending on severity, whether it is on this, if it is on displaced fracture or minimally displaced fracture, then we don't have to fix, we don't have to operate. So depending on the, there are 4 criteria for surgery. If there is no facial asymmetry, no reduction in mouth opening, no paresthesia. Okay. So in such cases, you don't have to operate. In such cases, no fixation is required. If you find any some clinical finding, if it is associated with any eye sign, if it is associated with facial asymmetry or mouth opening or paresthesia, then you have to do the surgery. Once you have to reduce the bone, once you have reduced the fragments, then depending on the severity, it may be 1-point fixation or 2-point fixation. You have to fix the plate either at the 1 point or 2 point, or at 3 places, or at 4 places, or sometimes maybe at all 5 places. The point of fixation are, the first one is frontozygomatic or zygomatic frontal suture area. You have to fix the plate in this area where 1.5, the system is 1.5 mm system, and the size of the screw is not more than 6 mm. So usually we use 1.5 by 6 mm screw. So if you are doing 1-point fixation, you have to fix the plate either at the zygomatico-frontal suture or zygomatico-maxillary suture. In case of 2-point fixation, you can fix at the frontozygomatic or zygomatico-frontal suture and infraorbital rim, or zygomatic maxillary suture or infraorbital rim. In case of 3-point fixation, you have to fix the plate as 3 places: zygomatico-frontal, zygomatico-maxillary, and infraorbital rim. If still the fragment is not stable, then you have to fix the plate at 4 places. The 4th one will be zygomatic arch. And at last, the 5th point of fixation is sphenozygomatic suture. And practically, you may not need 5th point fixation. If you fix the bone at 4 places, it is sufficiently rigid. Even if you fix the plate at 3 places, even if you fix the bone fragment at 3 places, it is sufficiently immobile. It is rigid. You don't have to fix the plate at 4-point fixation or 5. You don't have to do a 5-point fixation. So most of the time, practically, we do maximum 3-point fixation. Okay. In any bone fragment, if you fix the bone at 3 places, it is sufficiently immobile. It is rigid. Just so you don't have to worry. Okay. In case of orbital floor reconstruction, you have to approach through the subciliary approach. There are many approaches like infraorbital approach, but the problem with infraorbital approach is you will get the unsightly scar. The aesthetic problem is there. You can give the subciliary incision. In case of subciliary incision, a scar mark is hidden within the eyelashes. The next option is you can give the incision directly within the conjunctiva. That is called transconjunctival approach. In the transconjunctival approach, you have to give the incision inside the eyelid. Okay. So you will not find any scar mark. Aesthetically, it is good. And also once you give the incision in the transconjunctival approach, directly after giving the incision in the conjunctiva, you will reach the bone. There are no any other layer, there are no any muscle layer or anything. So directly you can approach the orbital floor. In case of orbital floor fracture, you have to explore the eyeball, you have to reduce the fracture fragment, and in this condition there is paper thin bone, you can reduce and fix this bone. So you have to do the orbital floor reconstruction. It is not reduction and fixation. Unlike other bone, you can reduce and fix the orbital floor fracture because it is a paper thin bone, you can put any plate here. So you have to put the orbital mesh, and you have to support the globe of the eye. And usually in case of orbital floor fracture, what happens, the content of the eyeball or content of the orbit is extruded into the maxillary sinus. So you have to reduce all those extruded part, and then you have to put an orbital mesh in the floor. And you have to put a screw at the infraorbital rim. You can't put a screw within the floor. Or the other alternative is, if the orbital floor is fractured, sometimes you can put bone graft as well, as shown in the last figure. But practically it is difficult. The easiest one is nowadays commonly used are the orbital mesh, that is made up of titanium. It is very thin plate. You can directly put a titanium orbital mesh in the orbital floor, and you can do the orbital floor reconstruction. So in case of 1-point fixation, the ZMC fracture, practically what we do, or what is indicated is, whenever the ZMC fracture, first you have to reduce the bone. After reduction, you have to palpate the window, you have to give the digital pressure. If it is still immobile, then you have to do fixation. If it is not mobile, then you don't have to do any fixation, zero fixation. Plating is not required. Okay. Now you have to fix the zygomatic bone at any one place, either at the frontozygomatic suture or zygomatic maxillary suture. After fixation at one place, again you have to palpate the fracture fragments. You have to apply the digital pressure. If it is immobile, then leave it as it is. If it is still mobile, then you have to do another next fixation. Then go for 2-point fixation. Now the question is, where will you put the plate? Whether at the zygomatic maxillary suture area or frontozygomatic suture area. So the general concept in case of fracture reduction is, in case of panfacial fracture is, you have to always proceed from a stable area to unstable area. Okay. Usually what happens, there may be chances of comminuted fracture in the maxillary sinus area because there is very thin bone. So, and usually the zygomatic frontal suture is rigid. So most of the time, comminuted fracture is not present in this area. So depending on if it is a comminuted fracture, then you have to apply the plate at the zygomatic maxillary suture area. If this area has a comminuted fracture, then you have to apply the plate at zygomatic frontal suture. So always proceed from a stable area to unstable area, because in case of panfacial fracture, what happens? There is comminuted fracture. You can't find any stable anatomical landmarks. In that case, you have to always proceed from the most stable area. Then you have to do the fixation of the unstable area at last. Okay. So after fixation at one point, you have to check, you have to apply the digital pressure. If it is still mobile, then you have to again put another plate, and you have to proceed for 2-point fixation. At 2-point fixation, you have many options. Either you can put a plate at the zygomatic maxillary buttress area and infraorbital rim. Okay. After placing the two plate, again you have to palpate. You have to apply the pressure, digital pressure. If it is rigid, well and fine. If it is still mobile, then again you have to proceed for the next point fixation. So in case of 2-point fixation, either you can put the plate at the zygomatic maxillary buttress area and infraorbital rim, or you can put the plate at the ZM buttress or frontozygomatic suture area, depending on where you find the stable bone. If there is no comminution, a stable bone is there, you can put the plate. Even after placing a 2 plate, and you can, after doing a 2-point fixation, if it is still rigid, if it is still mobile, it is not rigid, then you have to go for again 3-point fixation. That always depends on severity of injury. You have to check intraoperatively. In 3-point fixation, you have to put the plate at the zygomatic maxillary buttress area, frontozygomatic buttress area, and infraorbital rim. It is 3-point fixation. It's easy. Okay. Now, for 4-point fixation, again, along with these 3 fixation, you have to put the plate at the zygomatic arch area. And you have to remember that in all other places, we have to use 1.5 mm system, the thin plate in case of zygomatic arch, because it is a thick bone and masseter muscle is also attached there. So you have to you have to plate with 2 mm system. You have to place the 2 mm plate and monocortical screw 2 by 6 mm. Another thing, in case of zygomatic arch, even though it is considered as arch, but you have to put a straight plate. Okay, you don't have to bend the plate. If you bend the plate, there will be outward bulging. Now the last point of fixation is at the sphenozygomatic suture at the lateral wall of the orbit. Theoretically, they say that if it is not formed, then you have to do 5-point fixation at all articulation area with all the 4 bones at 5 places. So after placing sphenozygomatic suture, it's considered as 5-point fixation, but practically you never need fixation at the sphenozygomatic suture because it is present at the lateral wall of the orbit, and most of the time this suture is not fractured. So intraoperatively, what happens whenever there is a comminuted fracture or panfacial fracture, there may be chances that all 4 articulation may have been disrupted, but in most of the time the sphenozygomatic suture is still intact. So for us, clue is that whether the bone is reduced or not, you have to look for the sphenozygomatic suture. If the bone is reduced in this area at the sphenozygomatic area, sorry, hello. Lots of detail put here. Name is sorry. Name is so practically you have to look at the sphenozygomatic suture, because whenever you are reducing intraoperatively, you don't have any clue whether the bone is reduced sufficiently or not. Okay, it is in a 3D space. So you have to look at the sphenozygomatic suture. If you have the sphenozygomatic suture, if it is well maintained, if the bone is approximated, then it is considered that the bone is reduced, and now you can proceed for the fixation after reduction. So the fixation varies from no fixation to 5-point fixation. Practically, most of the time you have to do not more than 3-point fixation. Once you apply the plate at the 3 places, the bone is sufficiently rigid. You don't have to apply 4-point fixation or 5-point fixation, but theoretically you must know there sometimes you have to do 5-point fixation as well. Now complications are periorbital incision problems. Periorbital incision, there is something called as ectropion or entropion. Have you heard the term ectropion and entropion? Ectropion means if you give the subciliary incision, when you suture, what happens? The eyelashes which are present, it will come out like this due to suturing at the subciliary region. That is known as ectropion. If the eyelashes bulge outward, it is known as ectropion. In case of entropion, what happens is when you give the transconjunctival incision inside the conjunctiva, the eyelashes will go inside. Okay, that is known as entropion. Entropion is much more problematic than the ectropion, because what happens when there is entropion, eyelashes will produce abrasion on the conjunctiva and cornea, so it will lead to damage to the eyeball. So outward extrusion of the eyelashes is known as ectropion. It is one of the complications of subciliary incision. Entropion is complications of transconjunctival incision, where the eyelashes causes abrasion over the cornea and conjunctiva. Another complication can be infraorbital nerve disorder, because you are giving the incision just below the infraorbital rim for the exposure of orbital floor fracture. In such cases, there may be chances that you may damage the infraorbital nerve. If the infraorbital nerve is damaged, there will be paresthesia over the upper lip, lateral wall of the nose, and lower eyelid. Another complication can be implant extrusion, displacement, and infection. If you have not fixed the implant properly with the screw, or if you have put the screw at the fracture site, or if the bone is necrotic, it is dead bone, or if it is a paper thin bone, the implant is not rigid, it is mobile, so it may extrude. And usually what happens in case of old age patient, the skin is thin. In such patient, there may be chances that the plate will come out after a few years. Hello? Hello? Sorry. Another complication is persistent diplopia. If you are reducing the ZMC fracture, if the orbital floor is fractured, and if you have not reduced the fracture properly, the most commonly inferior rectus muscles get entrapped within the orbital floor, and you have to release the inferior rectus muscle. If the inferior rectus muscle is not released, the movement of the eyeball will be restricted, so it will lead to diplopia. So while doing the orbital floor reconstruction, you have the release the inferior rectus muscle which have been entrapped during the trauma. If the inferior rectus muscle is not released, it will lead to persistent diplopia. Another complication is in ophthalmos. If the orbital volume is increased, it will lead to posterior displacement of the eyeball, that is known as inophthalmos. If the eyeball is displaced posteriorly inward, it is known as inophthalmos. If just opposite is if the eyeball is protruded outward, if the orbital volume is reduced, that condition is known as exophthalmos. Inophthalmos will take place if the orbital floor or medial wall is fractured, and during reduction or during orbital floor reconstruction, if you have increased the volume of the orbit, it will lead to inophthalmos. Another complication can be blindness. During surgical procedure, if you have traumatized the optic nerve, it will lead to blindness. During orbital floor reconstruction, you have to explore till the posterior wall, till the optic foramen where the fracture fragment is present. So you have to explore all the fracture fragment, then you have to put the orbital mesh. And during exploration, if you injure the optic nerve, it will lead to blindness. Another complication can be retrobulbar hemorrhage or intraorbital hemorrhage due to rupture of the vein, ophthalmic vein, and other artery which is present within the orbit. Another complication can be malunion of the zygoma. If you have not reduced the bone properly, if the fixation is not proper, then it will lead to displacement of the fracture fragment, and that will lead to malunion. Now moving to orbital fractures. Again, the orbit is divided into three parts, the three sections. The anterior orbital section, it is made up of thick bony structure forming the orbital ring, as shown is the orange color. It is orbital ring, superior orbital rim, inferior orbital rim, lateral orbital rim, and medial orbital rim. The medial orbital section is shown in green color. It includes orbital floor, medial orbital wall, lateral orbital wall, orbital roof, and inferior orbital fissure. The fissure is present in the inferior at the junction of orbital floor and the lateral wall. Through this fissure, there are presence of artery, vein, and neurovascular bundle. In the posterior orbital section, this is made up of thick bone protecting the cranial nerves which enter through the apex, containing the optic foramen, the inferior and superior orbital fissure. Okay, this pink color is posterior section. It is made up of thick bone. It consists of optic nerve. You commonly get the question, what is hanging drop phenomena? In case of orbital floor fracture, what happens? The orbital content which is present within the orbit will be extruded into the maxillary sinus, and in the coronal section, you will find the drop-like structure. This is known as hanging drop phenomena. So hanging drop phenomena is present in orbital floor fracture. During orbital floor fracture, the orbital content is extruded in the maxillary sinus, and this drop-like structure is known as hanging drop phenomena. It is coronal CT scan demonstrating a blowout fracture of the orbital floor. In case of blowout fracture, the orbital content, mostly the periorbital fat, inferior rectus muscle, and other connective tissue will be extruded into the maxillary sinus, and this condition is this structure is known as hanging drop phenomena. So hanging drop phenomena is present in orbital floor fracture due to extrusion of orbital content within the maxillary sinus. Okay. There are two terms, blowout fracture and blow-in fracture. Usually, in case of eyeball or orbital floor fracture, it is most of the time it is blowout fracture. Blowout fracture means the orbital content is extruded outside the orbit. That's why it is known as blowout fracture. Another term is blow-in fracture. In case of blow-in fracture, what happens? Sometimes in case of bullet injury, or if the trauma is from the inferior surface, in that condition, what happens? The orbital floor is fractured, and this orbital floor structure bone will extruded into the orbit. Okay, inside the orbit. It is known as blow-in fracture. Though blow-in fracture is rare, but sometimes it happens if the direction of trauma is from the inferior surface, from outside through the maxillary sinus. In that condition, what happens? The orbital floor will be fractured, and it will be intruded within the orbit. It is known as blow-in fracture. But in most of the cases, practically, there is a blunt trauma over the eyeball, so it will lead to fracture of the orbital floor. In case of orbital floor and medial wall, as compared to the lateral walls, orbital roof, orbital rim, and posterior section, the weakest part is orbital floor and medial wall of the orbit. It is made up of paper-thin bone. So whenever there is trauma, usually orbital floor gets fractured, orbital floor and lower part of the medial wall. And it will lead to blowout fracture. So blowout fracture is seen in case of orbital floor fracture whenever there is blunt trauma over the eyeball. Now, approaches for orbital fracture. Whenever there is when the orbital wall is fractured, then there are different approaches. You can go from bicoronal approach, lateral eyebrow incision, subciliary approach, infraorbital approach, transconjunctival approach. Okay. So area of possible orbital exposure as shown in pink color through local incision. If the trauma is minor, if there is minimally displaced fracture, you can give the just local incision. You don't have to give the big bicoronal incision. You have to explore all the frontal vein and all the structures. So depending on the severity, either you can proceed through the local incision, or you have to give the big bicoronal incision, or sometimes you have to give the both, because both of them have some limitations. If you give the lateral eyebrow incision, you can only explore the zygomatico-frontal suture. If you give the subciliary incision or transconjunctival incision or infraorbital incision, you can explore the inferior orbital rim or orbital floor. If you give the bicoronal incision, you can expose the supraorbital rim, zygomatico-frontal suture, but you can't explore the orbital floor. So sometimes you have to give both the incision, both bicoronal incision as well as other local incisions. This is the case of orbital floor reconstruction. This is orbital mesh. Most of the time, due to presence of paper-thin bone in the orbital floor and the medial wall, whenever there is a blunt trauma over the eye wall, it will lead to fracture of the orbital floor and medial wall. And in this condition, unlike other fracture, you can reduce and fix the fracture fragments because it is made of very thin paper-thin bone. So you have to explore the fracture, and you have to reconstruct with orbital mesh. This is known as orbital mesh. It is made up of titanium, and you have to fix this orbital mesh at the infraorbital rim, because for placement of screw, you must need the thick bone, strong bone. The thick bone is not present anywhere within the orbital floor or medial wall. So it is orbital floor reconstruction. This is known as medial extension, because the medial wall is also fractured in the lower part. So you have to do reconstruction of the medial wall as well. So it is known as orbital floor reconstruction with extended medial wall. If the medial wall is not fractured, if it is isolated orbital floor fracture, then you don't have to use this extension. Okay. Another important thing while doing the orbital floor reconstruction is you have to search for the posterior step. Posterior step means you have to explore where the fracture has been extended. You have to go beyond that. If you don't reach the posterior segment, what will happen? This orbital mesh will sag down. It will enter into the maxillary sinus, and then it will lead to increase in the volume of the orbit, and finally, clinically, you will see there is enophthalmos. So you have to be careful. You have to extend the orbital mesh beyond the fracture posteriorly. Okay, the fracture is shown in the red line with a red color. So the orbital mesh is extended beyond this red color, beyond this fracture line. You have to extend your orbital mesh beyond the fracture line so that it can hold the orbital content. And in this condition, even 1.5 mm screw is very big. Just you can use a 1.2 mm system, 1.2 by 4 mm screw. Because this in the midface, they are not the load bearing area, unlike mandible. So you don't need a thick bone, long and very thick plate and long screw. Okay, these are not a load bearing area. So you can use a simple small screw. 1.2 by 4 mm is sufficient in this case, in case of orbital floor reconstruction while you are using orbital mesh. This is the clinical picture. We have operated this case. It was a case of orbital floor fracture. So orbital floor was fractured. All the orbital content was extruded into the maxillary sinus. Inferior rectus muscle was entrapped. There was diplopia. Okay, so during surgery, we went through the transconjunctival approach. We have reduced the fracture. We have reduced the released the inferior rectus muscle. Then we have done the orbital floor reconstruction. Orbital mesh is present, we placed in the orbital floor, and it is fixed with the just 1.2 or 4 mm screw at the inferior orbital rim or infraorbital rim, because only the thick bone present in this area is rim area. Within the orbit, in the floor or the medial wall, you will not find any thick bone. They all are paper thin bone. And this is the post-operative CT scan. You can see this is the orbital mesh. Okay. Inferior rectus muscle, which was entrapped, has been released, and orbital floor reconstruction was done. And there is also the medial extension. This is the medial extension. The medial wall was also fractured. It is post-operative CT scan of same patient. Next is naso-orbitoethmoid injuries. It is also known as NOE injuries or NOE fracture, naso-orbitoethmoid fracture. As shown in figure, this is a nasal bone. There is pair of nasal bone present in the central area of the mid face, and the most common bone which is fractured in the maxillofacial area is its nasal bone fracture is the most common fracture in the maxillofacial region. Because it is more prominent, it is present in the center. Whenever there is trauma, it gets fractured. It is also thin bone. So most commonly, the bone which is fractured in the maxillofacial region is a nasal bone fracture. Another structure is nasal septum. It is made up of cartilage. This is a part of a frontal bone. This is parts of, it is also known as either frontal process of the maxilla or nasal process of the maxilla. It articulates with the frontal bone. This is the lamina papyracea. It is a part of ethmoid bone. It forms the medial wall of the orbit. Okay. It is a coronal section, so interorbital space, interorbital distance. Green arrow indicates potential site of cerebrospinal fluid leak. CSF leak is commonly come across the CSF leak in case of mid-face fracture. So there are two paths for cerebrospinal fluid leak in the whenever there is mid-face fracture. In case of Li4-3 fracture, in almost all the time, in every cases, you will find the CSF leakage. In case of Li4-2, CSF leakage may or may not be present. It depends whether the intercranial fossa is fractured or not, and dura mater, arachnoid, and pia mater, the meninges are teared or not. In case of Li4-3, it is teared. There is CSF in all the cases. There will be CSF rhinorrhea in case of Li4-3 fracture, but in case of Li4-2, it may or may not be present. In case of Li4-1, there will be no CSF rhinorrhea because the Li4-1 fracture does not involve the intercranial fossa. So in case of CSF leak, there are two pathways. The one pathway is whenever this intercranial fossa is fractured, it will directly enter in the CSF will directly drain into the nasal cavity. Okay, so one pathway is this one. It will directly drain into nasal cavity and it will come out of the nostril. Okay, so you'll find there will be tramline appearance. The clear fluid will be leaking from the nasal cavity, and the problem is whenever there is trauma, it is always mixed with the blood. So you have to search for tramline appearance or something we call as halo. The blood which is clotted is present in the center, and the non-viscous clear fluid will be present in the periphery, that is known as halo. So here we are suspecting a CSF leak. The confirmatory test for cerebrospinal fluid is, how will you confirm whether it is the fluid is CSF or not? Because there may be nasal secretion. There may be secretion of maxillary sinus. There is something called as beta-2 transferrin test. Beta-2 transferrin test is a confirmatory test for CSF leakage. If the beta-2 transferrin test is positive, it is considered that it is confirmed that it is a CSF. So one path is from the intercranial fossa to directly, it will come directly into the nasal cavity due to fracture of this floor of the floor in the intercranial fossa. So it will lead it will fracture the ethmoid bone, and the CSF will leak directly into the nasal cavity. Another path will be intercranial fossa is fractured, the CSF will enter into the frontal sinus. From the frontal sinus, it will be drained into the opening of frontal sinus is present in the nasal cavity, and through the nasal cavity again it will come out of the nostrils. So there are two pathways. Either it will directly fracture the central region, it will enter into the nasal cavity. Another pathway is the CSF will enter into the frontal sinus. From the frontal sinus, again via the drainage of the frontal sinus, it will enter into the nasal cavity. Finally, it will come out of the nostril. Commonly, CSF leakage is present in case of Li4-3 fracture. If it is NOE fracture, if the ethmoid bone is fractured, then in such condition there will be CSF leakage. In case of NOE fracture, it is classified into three types. It is commonly It has a Markowitz classification of NOE fracture. It is type 1, type 2, and type 3. In case of type 1, what happens? The medial canthal ligament is attached to the thick bone, the large bony segments, so that you can reduce this bone fragment with the plate and screw easily. It is type 1. In case of type 3, there is comminuted fracture. The medial canthal attachment is completely disrupted. You can't reduce and fix this bony fragment. There is comminuted fracture and medial canthal ligament is completely disrupted. Okay, in case of type 3. In case of type 2, there is comminuted fracture, but still the medial canthal ligament is attached to some bony parts, so that you can reduce and fix this bone. In case of type 1, there is simple fracture, single fracture, medial canthal ligament is still attached to the large bony fragments. You can reduce and fix these bony fragments with the help of 1.5 mm plate and screw. In case of type 2, the medial canthal ligament is still attached to some bone, but there is comminuted fracture, but we can still reduce and fix this bony fragment with the help of 1.5 mm plate and screw. In case of type 3, what happens? There is comminuted fracture. The medial canthal ligament is not attached to any bone, or even if it is attached to the small bone pieces, you can reduce and fix that bone. So in that condition, you can reduce and fix the bony fragment. So in type 1, there is single central fragment bearing the canthal ligament. In case of type 2, there is comminuted central segment with medial canthal ligament is still attached to a bone fragments. In case of type 3, there is comminuted central segment with totally detached medial canthal ligament. Okay. The clinical feature in case of NOE fracture will be there will be deviation of nose, increase intercanthal distance. If the intercanthal distance is more than 40 mm, then we say that there is intercanthal distance is increased. If it is less than 35 mm, then it is normal. There may be epistaxis, nasal bleeding. There may be presence of CSF rhinorrhea if the ethmoid bone is fractured. In case of NOE fracture, most of the time ethmoid bone is also fractured. The intercanthal fossa is ruptured, so it will lead to CSF rhinorrhea. There may be subconjunctival hemorrhage. Periorbital edema may be present, and also there will be presence of periorbital ecchymosis. This periorbital ecchymosis, periorbital edema, subconjunctival hemorrhage may be present in any fracture when there is fracture of bone around the orbit. It may be NOE fracture, nasal bone fracture, ZMC fracture, supraorbital rim fracture, LeFor-2 fracture, LeFor-3 fracture. All the fractures which are present adjacent to the orbital rim will lead to these clinical features. Now, for fixation or treatment of NOE fracture, in case of type 1 fracture, it's easy because the medial canthal ligament is still attached to the large bone fragments. So you have to put one plate superiorly at the medial wall. Second plate you have to place at the nasomaxillary buttress. Third one at the infraorbital rim. You have to do 3-point fixation in case of type 1 fracture. It is NOE fracture, Markowitz type 1. Fixation of type 1 NOE fracture. In case of type 1 fracture, you can put the plate at 3 places, one at the superior region, another at the infraorbital rim, third one at the nasomaxillary buttress. Always in the midface, you have to remember the buttress area. You can only use plate and screw in the buttress area. You can't put a plate and screw in the thin bone. You can't put any plate and screw in the interior wall of the maxillary sinus. Okay, so the buttress area are nasomaxillary buttress, zygomatic maxillary buttress, infraorbital rim, supraorbital rim, lateral wall of the orbit, or zygomatic frontal suture area, or medial wall of the orbit. Okay, if there is bilateral fracture, then in such cases you have to put the plate at the infraorbital rim, nasomaxillary buttress bilaterally, and in superiorly you don't have to put a 2 plate. You can put single Y-shaped plate, so it can hold bilateral fracture fragments. Now, in case of type 2 and type 3 fracture, as you know, in case of type 2 and type 3 fracture, there is comminuted fracture, so you have to reduce all the bony fracture and fix it. Okay. Now, the problem with medial canthal ligament, because as you know, in case of type 3, the medial canthal ligament is completely detached from the bony fragments, and you can reduce that bone fragments with a plate and screw. So what you have to do is, the best thing is just you put a 1 plate at the medial wall, put a 3 screw, make some hole free, and you can attach this medial canthal ligament with this plate. So it will act as a cantilever. Okay. Another is you can put 1 screw in the contralateral side, then you have to attach the medial canthal ligament with some 21 or 24 gauge wire. Then you have to Again, pass the wire through the bone on the contralateral side, and you have to attach this screw with the wire. It will also hold the medial canthal ligament, but it is more cumbersome to attach the medial canthal ligament with the contralateral side screw. It's easy. Just put one cantilever plate, and you can attach this medial canthal ligament with the help of non-resorbable suture, either 3-0 Prolene suture or nylon suture. And here you hold the medial canthal ligament and attach with this cantilever plate. It is easy. The next thing is same. You have to put the plate at the nasomaxillary buttress, infraorbital rim, and also at the superior region in the medial wall of the orbit. And if still there is some comminuted fracture which are not reduced, you have to put the extra plate in the central region as well, in the medial wall of the orbit, where the bone buttress is sufficient. And depending on the type of fracture, if there is comminuted fracture, you might have to use the long plate. Usually, if there is single fracture, what we do, we place just 2 screws on either side of the fracture in case of mid-phase fracture. But if there is comminuted fracture, you have to hold all the fracture fragments. You have to stabilize all the fracture fragments. In that condition, you might have to use long plates. Sometimes you might have to use 20-hole plate that extends from the nasomaxillary buttress to the frontal bone. There will be a straight plate extending from this nasomaxillary buttress, medial wall of the orbit, till the frontal bone. Usually, in case of mandibular fracture, we use such long plates because all the bone are disrupted. There is comminuted fracture, small pieces of bone are there, so you will not find any stable part. And in that condition, you have to use a long plate. Fixation of nasal bone in NOE fracture for positive brown gross vault compression test suggests that a cantilever primary bone graft will be required. The proximal nasal bones are reduced and fixed to the glabella with a X-shaped mini plate, taking care to restore the nasal frontal angle. This brown gross vault test it indicates whether there is a comminuted fracture is present or not, whether the fracture fragment is stable or not. If it is not stable, then you have to use plate and screw. Sometimes what happens, it is so severely injured that you might have to use bone graft. You have to reconstruct the nasal septum, and you might have to reconstruct the nasal bridge. Suppose brown gross vault test, compression test is used to check whether the nasal bone is stable or not, whether the comminuted fracture is present or not, whether you have to fix it or not, whether if it is a severely injured, if it is comminuted fracture, then sometimes you might have to use bone graft to reconstruct the nasal bridge. So if the nasal bridge is comminuted fracture, if you can't reduce, if there are small pieces of bone in that condition, you might have to use bone graft, and you have to stabilize the bone graft with this cantilever plate. Okay. Split skull bone fixed as a cantilever graft to reconstruct the nasal dorsum. Fixation with a single plate from the glabella to the dorsal nasal graft. If the interior part of the nasal bone is completely fractured, so you have to reconstruct the nasal bridge with the help of cantilever plate, and you can take the graft either from the calvarium, or preferably we always take the graft from the interior part of the iliac crest. But theoretically, you can take it from the calvarium or ramus area or chin area or ribs or fibula. There are many options. Now, another thing is meter lead splint padded with a foam used as external bolster contoured to the nasal surface for the adaptation of the soft tissue of the nose. Application of this should be done with great caution to avoid skin necrosis. What happens in case of NOE fracture and nasal bone fracture is, even though if you reduce the nasal bone or the frontal process, the maxilla, all the small pieces of bone which are present in the mid face, but still there is problem with the soft tissue. What happens in the post-operatively, if you see the patient after a few weeks, even though the bone is properly reduced, in CT scan you will not find any abnormality, all the bone are reduced, but there is problem with the soft tissue. There is bulging of the soft tissue in the bridge of the nose. The appearance there will be aesthetic problem for the patient. So in order to adapt the soft tissue over the nasal bridge, you have to use such type of bolster. Usually we prefer thermoplastic splint is there. So thermoplastic splint is like that. Whenever you put it in hot water, it will become soft. So we have to you can bend it like a shape of a nose. So you have to apply it over the nasal bridge. Then you have to tie it with a 40 or 50 Prolene suture. You have to place it for a few weeks. Once the soft tissue is healed, you can remove this thermoplastic splint. The nature of a thermoplastic splint is something like a impression compound. Whenever you put it in a hot water, it becomes soft. Once you apply over the nasal bone over the nose. Once you make the shape of the nose, you can tie it with the 50 Prolene suture. After a few minutes, once it is dry, it will become hard. So our aim is to give the proper shape to the nasal bone or nose. And again, you have to remove it after 2 to 3 weeks. This is another nasal bolster. Nasal bone fracture. If you see the anatomy of the nasal skeleton at 45-degree angle view, there is this is the nasal bone. It is present in pair. The most commonly, the bone which is fractured in the most maxillofacial region, nasal bone fracture. And for the diagnosis of nasal bone fracture, either you have to do CT scan or you can take the lateral skull view. You can diagnose whether the nasal bone is fractured or not. So this is a nasal bone, and there is bone cartilage junction. This is a junction of the bone and cartilage. The upper part of the nasal bridge is made up of nasal bone. The lower part is completely made up of cartilage. And whenever this cartilage is fractured, you can't put any plate, screw. You can't reduce or fix the cartilage. As you know, the cartilage is a vascular structure. Okay, so whenever the cartilage is fractured or if it is traumatized, you can't do anything. You have to go for graft because it will undergo necrosis because it does not have its own blood supply. It depends on surrounding structures for indigestion. This is ascending process of maxilla. It is also known as frontal process of the maxilla or nasal process of the maxilla. This is upper lateral cartilage. Okay, this is lower lateral cartilage. These two structures are lower lateral cartilage, and these are known as lateral cross-alar cartilage. These are the cartilage of the nose. So sometimes during the nasal bone fracture, the bone fracture may be associated with this cartilage, trauma to the cartilage or fracture of the cartilage as well. It is a medial cross. It is also made up of cartilage. This is known as lateral cross. This is central nasal septum. And it is anterior nasal spine. While operating in the mid face, you commonly come across this anterior nasal spine. You have to put the plate just below this anterior nasal spine. It is a thick, bony prominence. You can't put the plate either above this or just over this. You have to always put the plate just below the anterior nasal spine, because most of the time whenever you treat the leaf fracture, it may be associated with palatal split. In case of palatal split, you have to put the plate in the interior region of the maxilla. So if you see the type of nasal bone fracture, in the first figure, it is a centrally depressed nasal bone fracture. The nasal bones are pushed posteriorly inside the process of the maxilla. Okay, so the nasal septum is also fractured, and bilateral there is fracture disruption of the dorsum of the nose. So if the force is directly from the anterior region, it will lead to trauma. It will damage the bilateral structures as well as it will damage the nasal septum. If the direction of your force is from the lateral side, or if it is at an angle of 45 degree, then this type of fracture and displacement will be different. In case of lateral displacement of the nasal bones, septum is not displaced in the first figure. In the second figure, there is involvement of the superior portion of the nasal septum. It is a CT scan of patient with nasal bone fracture. You can see there is disruption of the nasal bone. Okay, it is displaced to the left side. So direction of trauma is from the right side. So the nasal bone is fractured and displaced to the contralateral side. Again, if the direction of force from the lateral side, it will be displaced to the contralateral side. Upper lateral cartilage avulsion after significant localized central third nasal trauma. And there is septal hematoma after isolated septal fracture. Sometimes what happens, whenever there is septal fracture, it will lead to septal hematoma. And the important thing in case of septal hematoma is, as you know, the nasal septum is made up of cartilage. it does not have its own blood supply. It depends on the surrounding structure. So whenever there is trauma over the nasal septum, if there is septal hematoma, it is emergency condition. You have to drain the septal hematoma immediately, because if you don't drain this hematoma, what will happen in normal condition? What happens? This cartilage will get the nutrition, oxygen, as well as other sugar and other nutrients from the surrounding mucosa. So whenever there is septal hematoma, there will be disruption of the mucoperiosteum. So the nutrition blood supply to this structure is reduced. There will be no supply of oxygen and other nutrients. So it will lead to avascular necrosis. So in order to prevent the septal necrosis, you have to drain the septal hematoma immediately. It is also one of the emergency conditions. Whenever you find a septal hematoma, you have to give the incision and drain it immediately. Otherwise, it will lead to necrosis of the nasal septum. Now, how will you reduce the nasal bone fracture? Commonly, you can come across the nasal bone fracture in emergency. Reduction in position control of the laterally displaced left nasal bone fracture with an elevator inside the nose and index finger outside the nose. What we do is, there are some forceps as well, or what you can do whenever there is nasal bone fracture, and it is most of the time it is depressed fracture. So in order to control the pain, you can give lignocaine gel. You have to apply the lignocaine gel over the nasal cavity. Then you can insert any periosteum or any blunt instrument. Once the instrument is inserted into the nasal cavity, first you have to measure the distance from this alar cartilage or alar of the nose to this area, the fracture site, and you have to insert the periosteum or any blunt structure inside the nose, and you have to then pull it outward. And again, be careful. You have to put your index finger outside the nose so that you don't disrupt the nasal mucosa. Once it is reduced, leave it as it is. On the forceps available, it is another Walsam's forceps. It is used to reduce the fractured nasal bone. If the nasal bone is fractured, you can use this Walsam's forceps and you can reduce the fractured nasal bone. It is asked many times, what is the use of Walsam's forceps, or which forceps is used to reduce the fractured nasal bone? So Walsam's forceps is used to reduce the fractured nasal bone. So Walsam forceps are two-part. The outer part is coated with any. You can just, if you don't have such a forceps, you can just use any cotton or gauze pack so that you don't traumatize the outside soft tissue. And you have to insert one of the beak inside the nasal cavity on the outside, and once you press, all the fracture fragments will be aligned together. It's simple. It is also non-surgical treatment, or close. We say it as a close reduction. So close reduction can be done with the help of Walsam forceps in case of nasal bone fracture. And the problem with nasal bone fracture, whenever you approach through the nostril, there will be severe bleeding from the nasal cavity. You have to be careful. In such cases, you have to place a nasal pack. You have to change it after 24 hours. Also, for 24 hours, you have to put the nasal pack. Sometimes what happens, anterior nasal bleeding will be there, no doubt. Sometimes there is posterior bleeding from the posterior nasal cavity as well. You will find the blood in the pharyngeal area, because the nasal cavity is highly vascular area. Whenever you put some instrument, it will traumatize the mucosa and it will do severe bleeding. So in such condition, whenever you reduce the nasal bone fracture, you have to pack the nasal cavity with nasal pack. And it should be sterile. It must be coated with any antibiotic ointment. Now, approaches for nasal bone fractures, you can use either big coronal approach. Through coronal approach, you can fix the nasal bone fracture from the superior area, or if there is existing laceration, if there is soft tissue laceration, you can approach through that laceration and you can reduce and fix the fracture area. Or also you can approach through the vestibular incision. You can give the vestibular incision within the oral, inside the oral cavity, and then you have to raise the mucoperiosteal flap and you can raise the nasal bone area. On the wrist, horizontal and vertical incision, it is also known as open sky incision. Open in sky incision is two types, either horizontal or vertical. It is the incision is given directly over the nasal bridge, and can explore the fracture fragment. You can reduce and fix it. The problem with open sky incision, such a vertical or horizontal incision, is there will be unsightly scar mark. There will be aesthetic problem. So it's better to avoid this. Okay, let's move to frontal sinus fracture. So injury pattern and recommended treatment. Or displaced fracture limited to anterior table should not affect a sinus outflow. Okay, so only the anterior table fracture. As you know, in case of frontal sinus, there is anterior table, there is posterior table, there is presence of air cavity, there is presence of air in this area, and there is outflow of frontal sinus, and it will drain into the nasal cavity. Okay, so let's consider if the only anterior table is fractured, posterior table is intact, then what will we do? A displaced fracture limited to the anterior table should not affect the sinus or outflow. So reconstruction and fixation of the anterior sinus wall with non-load bearing material is indicated. In this case, only the anterior table is fractured, the posterior table is intact, and also the outflow tract is intact. Outflow tract is not injured. In such cases, just you have to reduce and fix the anterior table with the help of 1.5 mm plate and screw. These are known as non-load bearing plates. Okay. Second condition is, now in this condition, see, the anterior table is fractured as well as outflow tract is disrupted. There is comminuted fracture of the anterior table, and frontal sinus outflow tract is also disrupted. Now in this condition, what will happen? Once the outflow tract is disrupted, the problem is if you reduce only the anterior table, if you don't consider for management of the outflow tract, in late case, what happens? There is a formation of mucosal because the frontal sinus is lined with mucosa. There will be accumulation of fluid, and pus, it will lead to formation of mucocele. It will expand, and in late cases, what happened? It may get infected. Once it gets enlarged, the surrounding bone will be resolved, so it will enter into either into the orbital cavity, the adjacent structure, or it will enter into the brain. In both the condition, either it will affect the eye, okay, or it will affect the brain. So in order to prevent such infection from the formation of mucocele, you have to curate all the lining of the frontal sinus, and you have to obturate this frontal sinus with either bone graft or fat pad or pericranium or any other muscles. Theoretically, there are many options. You can use either pericranial flap, or you can use any muscles, you can use any bone graft, or you can use buccal fat pad. The best one is you can use abdominal fat pad or any other fat pad. Okay, so you have to obliterate this frontal sinus with the fat pad. First, you have to remove all the sinus lining, then you have to obliterate the frontal sinus with fat pad. Okay, unlike the lining of the maxillary sinus and a nasal cavity or oral cavity, the sinus is firmly adhered to the bone. So you have to use round bore. You can't remove the lining with the help of periosteum or any hand instrument. It is firmly adhered to the bony structure. You have to use rotating instrument to remove the lining of the frontal sinus. If you don't remove the frontal sinus, if you leave as it is, after a few years, what happened? The mucocele will be formed within the frontal sinus because the outflow tract is obstructed. The accumulation with the secretion of the frontal sinus will be accumulated within this confined cavity. Once it is filled, it will lead to formation of mucocele. It will enlarge. It will cause resorption of the surrounding bone. So it will enter either into the brain through the frontal intercranial fossa, or it will enter into the orbit. It will affect the eye. So in order to prevent such complication, you have to remove the frontal sinus lining and obliterate it with either muscle or bone graft or fat pad or cartilage or something. You can't leave it as open. Okay, so the treatment is you have to remove the frontal sinus lining, you have to obturate it, you have to block the outflow because you have removed the sinus lining, and then you have to fix the anterior fracture fragment. And accompanying NOE fracture predisposes to outflow obstruction. In case of outflow obstruction, sinus obliteration is the preferred option. Whenever there is obstruction to the frontal sinus outflow, you have to obliterate the frontal sinus lining. You have to remove all the lining, and then you have to obliterate it with either the fat, buccal fat or abdominal fat or any muscles, or pericranial flap, or maybe sometimes celloplastic material as well. But preferably, it's always better to use fat pad. Now the next condition, combined anterior and posterior fracture also predisposes to outflow obstruction. Obliteration is preferred option if the posterior table is relatively intact and there is no evidence of dural injury. So in this condition, you can see the anterior table is fractured, the outflow is also obstructed. Also, there is fracture of the posterior table, but the posterior table is fractured, is minimally displaced. The dura mater is not here, dura mater is still intact. In this condition, again, you have to remove the frontal sinus lining, you have to obliterate the frontal sinus, then you have to reduce and fix the only anterior table. You don't have to do anything for posterior table because the posterior table is minimally displaced. There is no tearing of dura mater. Next condition, where both the anterior table and posterior table is fractured, there is leakage, CSF leakage, dura mater is teared, there is CSF leakage, and also the outflow obstruction is there. Now what will you do now? You can't reduce and fix the posterior table. In this condition, you have to remove the posterior table. Okay, when the posterior table is comminuted, as often seen with accompanying NOE fracture, the dura will usually be lacerated and CSF fistula may develop. The posterior table to allow repair of the laceration and craniolysis of the sinus. The pericranial flap enhances the seal of the floor of the sinus. In this condition, you have to remove the posterior table, okay, and you have to just reduce and fix the anterior table, and you have to obliterate this outflow also because already you have removed the sinus. You have to remove the sinus lining. Whenever there is any trauma to the outflow tract, if the outflow tract if there is obstruction in the outflow tract of the frontal sinus, you must have to remove the frontal sinus lining. Once the frontal sinus lining is removed, there will be no more secretion, so you don't need this tract. You have to seal this out tract with the help of pericranial flap or something. You have to reduce and fix the anterior table, remove the posterior table bone. Now what will happen? The brain will herniate into the frontal sinus, and this process is known as cranialization. It has also been used. What is cranialization in case of frontal sinus fracture? Cranialization means the extrusion of brain parenchyma within the frontal sinus. So it is indicated when the posterior table is fractured, there is CSF leakage, there is trauma to the tearing of the dura mater. In such condition, you have to remove the posterior table. So it will not happen immediately. You have to leave the frontal sinus as it is vacant. After a few months, or it may take sometimes 1 to 2 years, the brain parenchyma will herniate into the frontal sinus. And this process is known as cranialization. So whenever this posterior table is fractured, there is CSF leakage. In such condition, you have to do cranialization. And also, as there is CSF leakage, the dura mater is teared. You have to repair the dura mater as well. And it is done by neurosurgery team. It does not come under our specialty. Okay. We have to operate the frontal sinus, no doubt, but whenever the anterior canal fossa or brain part is involved, it is done by neurosurgeon. So we have to do the operation combinedly. They will do the intracranial part, we will do the extracranial part. So in case of frontal sinus fracture, you have to remember is if there is outflow tract, if there is obstruction of the outflow tract, you have to remove the frontal sinus lining. If you will not remove the frontal sinus lining, it will lead to formation of mucocele. It will damage the eye as well as the brain. So in order to prevent any damage to the brain or eye, you have to remove the frontal sinus lining. You have to obliterate it with, as your choice, you can use anything, but preferably we use fat pad. And you have to reduce and fix the anterior table. If the posterior table is fractured, if it is undisplaced, no need to worry, leave it. It will heal itself. If it is displaced, if it is displaced, then what happens? The dura mater is adhered to the posterior table, so your dura mater will also tear. Whenever there is tearing of a dura mater, there will be CSF leakage. If the CSF leak is there, then you have to remove the posterior table. You have to seal the dura mater. You have to suture. If you have to suture it, you have to control the CSF leak. Once it is controlled, you have to remove the posterior table, do fixation of the anterior table. You have to block the outflow tract. You have to remove the frontal sinus. Then you have to allow the brain parenchyma to herniate into the frontal sinus, and this process is known as cranialization. The cranium part intercranial part or the brain part will herniate into the frontal sinus. It is known as cranialization of the sinus. Again, there are different approaches. There is something called a subcranial approach in which they use the endoscope through the nasal cavity, and they use the camera and they operate the or seal the with the dura mater, which is ruptured in near the intercranial floor of the intercranial fossa. The subcranial approach will be considered for more extensive injury with disruption of the central third of the anterior skull base. A pericranial flap is essential for reinforcement of the facial graft used to repair the dura and bone grafts covering the skull base defect. In case of paranasal sinuses, also they use endoscope. Endoscope assisted surgery is there. That you don't have to give any incision, you have to just insert the endoscope, and there is some cautery. They will remove all the lining of all the sinuses, frontal sinus, maxillary sinus, ethmoid sinus, everything. Now, CSF rhinorrhea, it is associated with either NOE fracture, Li4-3 fracture, Li4-2 fracture, or frontal bone fracture. It is characterized by tramline appearance or central halos. Tramline appearance means there will be alternate lining of clotted blood as well as clear CSF fluid. Central halo will be present usually in the pillow. The clotted blood will be present in the central region, and in the periphery, it is surrounded by clear CSF fluid. So whenever you suspect a CSF rhinorrhea, you have to do beta-2 transferrin test. Beta-2 transferrin test is a confirmatory test for CSF rhinorrhea. So beta-2 transferrin test has also been asked. What is the confirmatory test for CSF rhinorrhea or CSF leakage? It is beta-2 transferrin test. You must remember this. Now, in case of midface fracture, we commonly come across such term raccoon eye, periorbital ecchymosis. Periorbital ecchymosis or raccoon eye are same thing. It is present if there is adamski fracture, orbital rim fracture, NOE fracture, or any fracture which is present around the orbit, it will lead to periorbital ecchymosis. So these are the appearance, and usually blood gets accumulated in the periorbital area because there is presence of loose areolar tissue, so it can hold the blood and will lead to periorbital ecchymosis. Usually in case of old age, the periorbital tissue is loose, so comparatively as compared to young patient, the chances of periorbital ecchymosis is high in case of geriatric patients. Pandaphysis may be present with, it may be associated with panfacial fracture, usually associated with Li4-2 fracture. On the moon face or disface deformity, it is also associated with panfacial fracture, where the multiple bone of the face is fractured. There is commited fracture of all the bones in the face. Okay, thank you. Hope you understood something. Okay, now I will